Welcome to the Long COVID podcast with me, Jackie Baxter. I am really excited to bring you today's episode. Please do check out the links in the show notes where you can find the podcast website, social media and support group, as well as a link to buy me a coffee if you are able. You should not rely on any medical information contained in this podcast and related materials in making medical, health-related or other decisions. Please do consult a doctor or other health professional. I love to hear from you. If you've got any suggestions or feedback or just want to say hey, then please do get in touch. I really hope you enjoy this episode, so here we go. Hello and welcome to this episode of the Long COVID podcast. I am absolutely delighted to be joined today by Dr. Diana Driscoll. So she's going to introduce herself a bit more in a moment, but we're going to be diving into PoTS and dysautonomia and how this relates to long COVID. And Diana's going to share a bit about her own story as well. So a very, very warm welcome to the podcast today. I'm so excited to meet you.
Thank you for having me, Jackie. I'm excited to be here, and I have enjoyed chatting with you too. Post-COVID is a deep interest of mine and a personal experience of mine. We'll chat about that. So I'm so happy to help others through this beast of a condition. There's always a way out of it.
Yeah, that's what we want to hear. So, before we get kind of really stuck into this, can you just say a little bit about yourself and what you do? Sort of
Absolutely.
overview.
I am an optometrist by education, but I don't do routine optometry anymore. But I'm the clinical director of PoTS Care at potscare.com. And I'm president of Genetic Disease Investigators. It was a corporation I set up to look into the genetics of some of these conditions. So those keep me busy. I also started a supplement company. We're at vagusnervesupport.com years ago when I started to write patents on some of this. So what I was discovering was new to everyone. And I felt like I need to put this on paper somewhere if this is really new. So I've gotten my 5th patent now, which is amazing to me. But it's been quite the journey. And as you and I mentioned, I got thrown into this. I didn't want to get thrown into this. I went kicking and screaming as a patient, and I didn't have COVID, but I was a post-viral dysautonomia or PoTS patient. And there weren't any answers out there. I was disabled over 10 years, and both of my kids ended up sick. My son got sick. He was 8 years old, and he missed over 3 years of school. We went everywhere for answers. I was even in clinical trials at our major research institution for 3 years. And their conclusion was that PoTS, dysautonomia patients were perfectly normal. We were just more aware of our own bodies. I was so upset that I decided, okay, I'm going to have to figure this out. If there's any hope in getting answers, I have the advantage of being in the body of one. I have children affected. I'm certainly motivated. I have medical education. I can start with the eyes. We don't have to end there. But maybe there's a chance we can figure some of this out. And it took many years, many layers. Patients are different. And once I got answers for my case, answers for my kids' cases, then it came to what research could we do to help others? What else could happen to pull people into a similar situation, PoTS, dysautonomia, and continue to tweak it, and then opened up PoTS Care years later. So.
Amazing. I mean, we were joking kind of just before we started recording, weren't we, about the lived experience being the qualification that you can't buy.
That's right.
You and we were kind of joking, but there's a lot of truth in
Mm,
that as well. That lived experience is so important. I think maybe particularly in these kind of, you call them maybe invisible illnesses or
mhm.
misunderstood illnesses
Yes.
that a doctor or a person who doesn't understand what it feels like
Right.
finds it very difficult to understand sort of fatigue, for example, because
Right.
fatigue not just tiredness. It's not just that you're feeling a bit knackered after a long day. It's
Right.
sometimes for some people that inability to even lift your head up. And for
Yes.
someone who hasn't experienced that, that can be quite difficult to understand. And I think a lot of the sort of, I don't know, feeling of chaos in the body that again is quite difficult to understand. So I don't know.
And
It's maybe something of a silver lining, or certainly something that you can't get any other way.
and
That
honestly,
maybe was helpful.
yes, no, absolutely. I think I would not have understood this condition had
Mm,
I not lived it. So I looked at the lack of validation I got from the doctors I saw, and I came to realize it's not like they were being mean or ignorant. They really, how would they know unless you have
yeah.
lived through it? You just can't know the misery. And we don't really have good vocabulary to describe a lot of it.
No.
I was asked things like, how much pain are you in? And initially, pain wasn't the real problem. And I'd say, well, it's not like a matter of the pain being off the charts. It's the misery of it. And I don't know how to describe that. And it was just head to toe. There was nothing that was unaffected. And then they start to think, there's no way all systems of the body could be affected. Then they give you that look, of, oh, maybe you're one of those. And you just lose validation. And it was incredibly frustrating. So only by walking away from all the traditional treatment and evaluation did I have a chance of even getting answers. Yeah, which was tough.
Yeah, and I think that's a really good point. The vocabulary isn't good, or certainly doesn't help with the understanding of things that you haven't experienced. Even something like
Yeah.
brain fog, for example, almost sounds kind of funny. But, people who have experienced brain fog, I don't think there's anything remotely funny about it.
No.
And even the long COVID label, I mean, this is probably not a debate we want to wade into, but, long COVID is so many different things
Yeah.
that, it's maybe not dismissive of the condition, but it's certainly not particularly helpful in terms of a diagnosis.
Right.
So, yeah, it's a challenge, isn't it? The sort of vocabulary around different aspects of it,
It
which is very, very
really
interesting.
Yes, and I think it's when I see patients and I pick apart these extraordinarily complicated cases and present this long array of this happened and this fell and this, this flow chart, if you will, and ta-da, this is what happened. Um, what I hear is, I just can't believe I get to talk to somebody who recovered. So, yeah, being able to relate to them is significant. And I don't know that there's another practitioner out there who can do that. So it's incredibly rewarding to be there for patients.
Yeah, I mean, yeah, I get the same. What you recovered, and
Yeah.
and for me, like the first person that I spoke to who had recovered, suddenly it was
Mhm.
like, you can recover, okay, so it totally changed my perspective on the whole thing. It
Right.
didn't happen quickly, and it wasn't fun, and it wasn't linear, and it was all of that, but
Right.
it sort of made me think, okay, it's worth doing some of these things. It's worth committing to, whatever it was, searching for some of these things. And it helped me kind of mentally to pull
Yeah.
myself out of some of the darkest points because I knew
Yes.
that, other people were recovering. Whereas up
Yeah.
until that point, I'd never even heard that someone could. So
Exactly.
I think that has a huge, huge value as well.
Yeah.
Um, so yeah, so speaking of language, PoTS, dysautonomia, long
Mhm.
COVID.
Yeah.
Um, can we sort of dive down into what is POTS? What is dysautonomia?
Yeah.
And sort of, yeah, demystify that a little bit for people.
Yes. And I think when we're dealing with the long COVID population, we don't have to dig too deeply into the many different forms of dysautonomia, because
Mm.
that's likely not what's happening. Things like, neurological disorders like ALS or something that can present initially with dysautonomia. That's not what they're dealing with. But when I got sick being post-viral, and we look back now and assume it was a SARS virus. I was with a group of people in Costa Rica and we all got sick. And all of us ended up, at least in the emergency room. We just couldn't breathe. It was horrible. It was hard to pull out of it. And we're very familiar with post-viral dysautonomia or POTS. And when COVID came along, I said, everybody brace yourselves. We need to be prepared. This virus could be significant enough, like other SARS viruses, to trigger POTS or dysautonomia in those predisposed. And it was, and we were ready. And we went immediately to remote. But I think one of the problems with POTS, and I'm air quoting, you can't really see that, is that POTS is not a disease. It is a presentation, purely that the heart rate goes fast when someone is vertical. So it's not done us any favors in trying to get help, because most every doctor out there who's not deep into an invisible illness will see POTS, see that label, postural orthostatic tachycardia syndrome, and say, oh, tachycardia, yeah, that's a heart problem. But in the patients we see, and we've seen thousands, we have literally never seen a patient with POTS due to a quote heart problem. We've seen an occasional, atrial fib, PVCs are very common, that sort of thing, but that wasn't the cause of POTS. So the label in and of itself is a problem. And I think dysautonomia needs to be looked at as, if it's not a neurological disease or driven by cancer, what have you, if it falls into the POTS realm, it probably should be labeled more POTS. But having said that, the commonalities between POTS, dysautonomia, long COVID are inflammatory. And in patients dealing with long COVID need to know, or likely need to know, if their heart rate increases when they're vertical. Because if it does, this inflammation could likely be affecting the cardiovascular system. And it affects more than that. But that effect on the cardiovascular system somewhat narrows the search for an answer. You don't have to look at every form of inflammation out there, which helps. So those commonalities and eventually changes in labels, I think, will be important. The labels won't end up being POTS, or dysautonomia or what have you. It will be the tendency to develop whatever abnormal inflammatory response is occurring. That's where the problem is. That should be the label. And patients need to know that label so that once they recover from this bout of whatever they're dealing with, they don't have to worry about getting it again. Would it be the next virus that comes along, to start them over on that horrible journey? That would be awful. Or even their kids, they probably need to know that. And that's one reason I set up genetic disease investigators. But what are the chances I could be sick? My kids could develop POTS. My husband was fine. We were in the same house and there's no genetic involvement of it. I don't think so. So once we have those objective labels, it changes the game. We're not dealing with this invisible illness. We have a genetic propensity and a measurable response that's abnormal, and that's what needs to be treated before these other dominoes fall. That was a long answer to, to your question. But I am on a mission to change that because I think the labels kind of work against us. And I think you've probably experienced it too, where you say POTS or you say post-COVID, and 80% of the doctors go, yeah, well, your heart's okay. Your lungs look okay. They look at you like it's your fault. And then they start to wonder if you just need counseling, which is so far from the truth, it's really upsetting for patients. And I went through that.
Yeah, and there was someone that said something to me about labels.
Mm,
That a diagnosis or a label is only useful if it leads you to a treatment pathway
thank
or,
you.
a list of things that are actually useful to you. Otherwise,
Yeah,
it's just a label. You're like, well, great, I got a label. What do I do with it? Stick it on my
right,
forehead. Um, you
right.
know, and I mean, we're being silly, but and maybe that's validating for people and it helps them to find their tribe. Or maybe
Yeah.
not, because everyone's got a different label, whereas actually they're all talking about the same thing under different names. So
Mhm.
it's this, what's helpful and what isn't.
Yeah.
But yeah, it is fascinating. And, it was fascinating what you were saying about genetics, but also about inflammation. Because
Hmm.
what we see is that can't remember exactly what the statistic is, but it's something like 70 to 80% of people with long COVID. And I think the stats are similar for ME/CFS and
Hmm.
for other
Yes.
sort of similar conditions, is that
Mhm.
it's 70 to 80% are females, and females by definition of biology tend to have much higher levels of inflammation, don't they? So that
Yeah.
links quite neatly into what you were saying, I think.
Yes, we do look at that. And the way we can evaluate patients is we do start with the commonalities.
Mm,
And then we look for the differences. And you're right, we see more females than males. And we know estrogen, especially estrogen surges that trigger menstrual cycles, are fairly inflammatory, especially to the blood vessels. So if someone is already struggling with PoTS, inflammatory PoTS, as I call it, and they have that cardiovascular response, that surge of estrogen does make it worse. Now, my son didn't have a surge of estrogen, what?
mm.
Right, and he was completely disabled. But I do find most of the male patients have less of a mountain to climb than the female inflammatory patients. Yes. So
Mm.
they can be struck with the same things, but I think not having to deal with those hormone changes is helpful. Yeah.
We'll be right back. I'm interrupting myself for a second to tell you about long COVID breathing. The fabulous Vicky Jones and I have teamed up to bring you long COVID breathing. We are both passionate about sharing our expertise and experience of the breath and how incredibly helpful that can be with long COVID. We've worked together to develop a course that is specifically tailored to those with long COVID. It's a 6-week course with 12 sessions, all delivered online. The community feel and learning that we're all sharing is such a joy. To find out more information and to sign up for our courses, workshops, and other shorter sessions, please check out the link below, longcovidbreathing.com, or email longcovidbreathing@gmail.com to start your breathing journey with us. Yeah, and again, that does make sense because, it's like if things are things being hormones and everything that is kind of triggered by them because they don't work in isolation, do they?
Yeah.
Are a little bit more stable, then you
Hmm.
have, there's less of a swing.
Yeah.
Whereas again, what we tend to see is that, females, that luteal phase of the cycle, you tend to
Hmm.
get, that's where you get your symptom exacerbation
Yes.
generally. It's where your resilience is lower. And again, you notice that in regular people that your resilience is lower, but obviously not to quite the same extent. So
Yeah.
again, it does all make sense. And and not to dismiss the experience of the guys who are
Right.
struggling,
Yes.
because we don't want to dismiss anyone's experience, but
Absolutely.
yes, I think those hormonal fluctuations definitely can add an extra level to it,
I do.
and possibly particularly for those women going into menopause and perimenopause, where things become sort of more chaotic, so to speak.
Yeah, chaotic,
Um,
probably a good word. Right. It's interesting because some of the symptoms of menopause also are similar to some of the symptoms of inflammatory POTS, like heat flashes. in POTS patients, we can get inflammatory episodes, and to
Mm.
the uninformed, they appear like a hot flash. They're so much worse than that. Is you get tachycardia. I mean, you feel hot, but then you feel extreme or fairly extreme panic and anxiety. It will take you to the emergency room. A regular hot flash, if you will, makes you hot. That's kind of the extent. But again, knowing patients intimately is really helpful to be able to pick apart some of that, how much of that is true hormones and how much of that is an inflammatory reaction. It's important to do that. But females, as you know, oftentimes when we go to doctors, especially around perimenopause, you could be missing a leg and they're going to blame your hormone fluctuations. It's really just wrong and so unfair, but it does happen. I've seen it over and over. Yeah.
Yeah. Whereas the truth of it is that it's probably some of each. That nothing works in isolation in the body, does it?
Right.
So, you have POTS, it's probably not going to help the hormones, and the hormones are probably, going to influence the POTS. So we have
Yes.
this kind of, horrible, vicious cycle.
Right.
But yes, oh yeah, just your hormones.
Yeah.
um, so, POTS and dysautonomia, um, somebody diagnosed with one or the other, in terms of treatment and what you would kind of look to do, are you sort
Hmm.
of treating them kind of largely the same, or is your treatment protocol very different, one versus the other?
Yes, I think it has to be different. Even my kids and I ended up not the same. Like, I never fainted. My blood pressure would surge sometimes when I stood up. My son fainted sometimes just trying to sit up, and his blood
Mm.
pressure would plummet. He and I were both disabled. My daughter was able to stay in school. She was much more functional, but she had more of the flushing, gut problems, and she couldn't stand still for 2 minutes without having to sit on the ground. So I thought there's different things at play, and there were. But just like the patients we deal with, what we did was start with commonalities. And I put this out, it's been almost 10 years ago, Jackie. I put out what's called the Driscoll Theory, the cause of POTS and EDS. And we started with there was a propensity to develop high intracranial pressure. We need to figure that out, treat it if that's the case. And that is always a secondary response to some sort of inflammation. Then we start digging into that inflammation. When I was watching the research on COVID, it was like watching my life and research play out very slowly, where they were starting to put some of it together. And now it's in literature that, yes, there's a propensity for high intracranial pressure, but as you'll see in the Driscoll theory, and I'll give that to anybody who asks, um, I had something to prove there because the MRIs oftentimes didn't show it. The optic nerve was typically not swollen. It was just so easy to miss, but it's disabling if it's not treated. And then I saw research was saying, why do patients with COVID tend to do better if they smoke? What's up with the nicotine? Oh no, that's, patented that almost 10 years ago. The use of nicotine stimulates a receptor on the vagus nerve, but nicotine is very inflammatory. You can't stay on that. And as it turned out, it was much more than a vagus nerve problem. It looked like it at first blush. But what I did over 5 years was I sent out symptom spreadsheets to chronic fatigue patients, POTS, fibromyalgia, and interestingly, PTSD. They also tend to show autonomic symptoms. And in this symptom checklist of about 150 symptoms, I tucked 30 some symptoms of anticholinergic syndrome. And the majority of patients had the majority of symptoms of that. So it wasn't just the vagus nerve, it involved other parasympathetic nerves, like pupils would tend to get big, eyes would eventually get dry. Some of the brain fog was low acetylcholine in the brain. And I was on a mission to figure out how to replace that to the degree, much like nicotine, that it would stimulate the nerve, but without the use of nicotine, and ended up with a supplement, Parasym Plus, which went around the world. And I remember days just sitting in my kitchen making this for my kids and I. And it went through a few revisions, but it wasn't a vagus nerve problem. It was a neurotransmitter problem. But use of the nicotine patch is what I used, tested the receptors of those nerves, and the receptors looked great. They worked fine. So all of the research at that point, or most of it in dysautonomia or PoTS, was put toward looking for an autoimmune condition that was shutting down these receptors. And I understand why patients exhibited like autoimmune patients. We tend to wax and wane, we're very inflamed, there's more autoimmunity in the population. But no one, which shocks me to this day, no one thought, well, let's test the receptors. Because if the receptors work, it's not an autoimmune condition tearing down the receptors. The receptors work great. So it was an essential part of figuring things out. And it probably should have been done many years ago. And we could throw out all that research involving autoimmunity as the cause of the problem and go ahead and correct it, which was awesome with, again, Parasym Plus, and then dig a little bit deeper into what was that causing? How could we turn that around? What was going on with the cardiovascular system? We just pick it all apart. Yeah.
So this Parasym Plus, now I'm not asking you to give away your recipe, but can you say a little bit about, like, what's sort of in it and what it does?
Yes, no, absolutely. Once I did the studies with nicotine and realized those receptors were working, what I looked for in the studies was a bowel movement. Even in those with complete gastroparesis, I leaned toward pretty chronic constipation, punctuated with episodic diarrhea. The diarrhea was thrilling because at least it would relieve the constipation. But I got to the point where then it was complete gastroparesis. I couldn't move my bowels at all, no matter what medicine they gave me, and my gallbladder wasn't working. And they wanted me to remove that. And I said, if it's looks like it's a healthy organ, they said, yeah, it wasn't damaged in any way. I asked if it was infected, like an appendix or something is going to blow. And I said, no, that looks fine. I said, is the opening maybe stuck closed where it can't eject? And I said, no, the opening's fine. I said, this sounds neurological. I would like an opportunity to try to figure this out because life is easier with a gallbladder if you can. And indeed, that's what it was. So initially, my goals when I sat down to try to create a supplement to do this was it had to trigger the vagus nerve. We had to have a bowel movement within about 45 minutes or so is what we looked for. It had to cross the blood-brain barrier. Part of the problem that my fatigue, and again, you said it's not even fatigue, I couldn't move. And then ultimately, it got so bad I couldn't stay awake. What turned from severe insomnia to severe, like narcolepsy, that was part of the problem. I had to cross the blood-brain barrier. And then something I'm very proud of is I looked into all the genetic issues why you could have problems creating enough of this neurotransmitter. And I thought if we're already challenged genetically, could this just be enough to push us over the edge? And if so, for each one of these conditions, how could I work around it? And then ultimately, patients who are not digesting properly, have vagus nerve problems, end up with some sort of malabsorption, malnutrition, and some nutrients are needed to create acetylcholine. So I researched that too and decided to put it all together so patients didn't have to know their genes, right? And it would work no matter what the issue was. And it was years in the making, but I'm very proud of that. So I got to use my ancient organic chemistry knowledge, which was, believe me, that was ancient, but I was a total geek in school. I overstudied all the time, and there's a reason for that. So I just sat down and figured it out. And then I had my lab rats at home, my kids and myself. And fortunately, or I guess that was fortunate, had gotten into the position where nothing else was working. I had to figure out something. So I was pushed into that very high motivation. And whereas the researchers I spoke to would go home at the end of their day at 5 o'clock and not think about it, I was in the body of one 24/7 and dealing with this every single day, every single minute, and had kids dealing with it. And so it was a different motivation to look for answers too. Yeah. So that was the first breakthrough, honestly, figuring that out. I'm pretty proud of that. Yeah.
Yeah, rightly so. And I think, I mean, you make a really, really valid point that again, someone who hasn't experienced an illness like this,
Yeah.
again, probably won't appreciate because how could they?
Yeah.
Is that you don't get a break from your
Right.
illness, and I used to make the distinction between myself and my partner, and life wasn't easy for him, because he was
Yeah.
having to look after me a lot. He was, having to do a job as well as make meals, as well as deal with the emotional side of it. And it
Oh my
wasn't
God,
easy
right?
to handle,
No, I wasn't
certainly some
either.
of the time. Plus probably watching someone he loved going through something horrendous and not knowing if she was going
Yeah.
to come out the other side. So I don't think he had an easy time of it. But what he was able to do was get away from it.
Yeah.
If he could go out for the day and enjoy
Right.
himself, and he was still coming back to it in the evening, but he could
Yeah.
get away, whereas I couldn't because I was in that body all the time.
Yeah.
And I think they sometimes say, don't you, that you have to hit rock bottom,
Mhm.
and that is where we become desperate enough to look
Yes.
outside the box or to consider things that maybe we wouldn't have considered before, or
Yeah.
to design your own supplement, dig
Right.
out your test tubes,
Right.
and literally make it, because you have that motivation, and it's like, well, nothing else I've tried has worked, so what have I got to lose?
Mhm.
And it sounds like that's kind of where you got to. I'm like, all right, okay, I'm gonna
That's
I'm gonna sort
exactly
it.
right. Yes, you have no other choice. I mean, for the first, I guess, 3.5 years of the illness, I leaned on all the experts, assuming they probably sort of knew what was going on and they would work me through this. And that just didn't happen. And I probably went to, oh, I don't know, 50 doctors the first 3 years. That was so discouraging. But you can get to the point where you have to figure something else out. And online was not good. It was just a horrible place to be. Everybody was sick. Everybody was mad. And then the mood disorders, would kick in. I was certainly one of those. So I couldn't get help online. I just had to go where I was comfortable, and that was studying and in my own mind and pick it apart. So yeah, not something I'd want
Yeah.
anyone to have to go through, but I feel like there is to some degree a reason for everything. And even my son's illness, which was the hardest thing I think to see, my own suffering was one thing, but his suffering was severe. And but that kept me motivated. He came to me when he was, oh gosh, 9 years old. And he said, Mom, you need to know I can't keep going like this. I can't even go one more day. And I had no answers at that point. And boy, that was a tough time. All I could do was validate what he was feeling and tell him I understood and that I was going to work through this problem and help us figure out what happened to us. And I would never give up. And that just gave him enough peace to go on. So the kids were hugely motivating for me too.
We'll be right back. Hey there, I'm just jumping in for a second to see if you're enjoying this episode. If you're finding it useful, maybe you would consider sharing it somewhere, a friend, a group, or even on your Twitter feed. If everyone was able to share just once, we'd be able to get this information out to even more people who really, really need it. So please consider sharing somewhere if you possibly can. I hope you enjoy the episode, and thank you so much. Yeah. And that must have been a very difficult thing, I imagine, as a parent to have to watch.
Yes.
Somebody that you care deeply for and that, are charged with their care. And you're
Yeah.
like, I don't know what to do.
Yeah.
I can't imagine that was easy either.
No, it wasn't easy on anyone. I wouldn't wish that journey on anyone. And my husband at the time, like you said, he at least he could leave. He could go
Mm,
somewhere and he would take business trips and stuff. But it was so hard to be left because I was so sick and the kids were sick. Um, and I was not in really good position to take care of anybody. So it's just a dynamic that no family should have to go through, right?
yeah,
At least without
absolutely.
validation, without somebody saying, oh, kind of like having cancer or something. Oh, well, we understand that. We know how sick you are. All your friends come and help. It's the chronic illness, like what we went through. We tend to lose our friends. We lose that support. They don't understand it. And even our spouses or family can get to the point where they don't understand it either and start to wonder if maybe we really are just mental, which is so far from the truth. But yeah, tough
Yeah.
journey. Mhm.
Yeah, absolutely. Um, so you said that I'm forgetting the name, Parasym Plus, I
Yes.
wrote it down,
Mhm.
was kind of step one.
Yes.
Can we talk a bit about what happened next?
Yes.
What helped you? What is now helping your patients? That's a very big question. Do
Mhm.
do with it what you will.
Yes, no, it's pretty much across the board in our inflammatory patients that they need that support from Parasym Plus. And not only does that digestion normalize, which is awesome, the heart rate has an opportunity at least to slow down and breathing slow down. And then we can usually see the pupils of the eyes get smaller within about 2 days. And it's not like they're abnormally getting small, it's they're normalizing. As patients, we tend to see get big pupils because of that abnormality in the autonomic nervous system. So when they can see something objective, and they can usually just look in the mirror in the bathroom, like in the morning or something, and see that, they know it's working, it's in place, it's just a matter of time, and you want to keep that going. And then high intracranial pressure, treating that, there's medicine to do that um, was huge for us. I remember telling the neurologist, okay, the rest of this I can handle. I at least have an opportunity to survive now, And then 2 or 3 years later, it was getting worse. I just couldn't. But it bought me some time. I will say we want to figure that out as quickly as we can. And then the other commonality we see, and it is across the board, is that the type of inflammation we deal with in this condition affects the cardiovascular system, vascular being important. And the blood vessels end up leaking, they're not healthy. Think about the blood-brain barrier, which is vascular. When that's not very healthy, things can get into the brain, the inflammation can spread and cause some fairly dramatic symptoms. It doesn't always show up on an MRI, which is important, but oxidation is always a consequence of inflammation. When you have inflammation, you always have oxidation. There is no exception to that. And the oxidation further damages the blood vessels. It can ultimately damage organs, and it changes the brain chemistry to more anxiety type symptoms. Sometimes it exhibits like anxiety, okay? And sometimes it exhibits more like this almost OCD, attention to detail, liking things a certain way. We're high achievers. We're usually at the top percent of everything we do as long as we're not too sick. And some of that is okay. I kind of admire a little bit of OCD, but it can get to the point where that anxiety type stuff and OCD type stuff becomes crippling and we're impossible to live with. For one, we expect other people to have the same same ideas that we do and they don't. And we want to be able to control that. If we don't get it in on top of the oxidation, it ignites more inflammation and you get caught in this really bad cycle. And I had the opportunity to go through that, which again, great, right? I was in the hospital. They gave me an antibiotic that it almost killed me, Jackie. It ignites inflammatory cells. And I went through probably 6 or 7 blood transfusions because the oxidation was destroying my red blood cells. And they started me on vitamin C, understanding the oxidation was bad. I didn't touch it. So when I got home, again, opportunity to try to figure it out, I came out with what's called NAC Max. And it increases glutathione and it also recycles the glutathione we produce. So it starts to immediately hit some of that oxidation. And when I was going through recovery, I just carried that bottle around with me. And every time I felt this kind of buzzy, oh, how do you describe this? Like hyperadrenergic fear. I was had a short fuse. I oddly developed a fear of heights that was dramatic. I couldn't even look at a picture of someone on a high height. I couldn't handle any stress whatsoever. Nothing, not even the thought of stress. And that's what pulled me out of that. So we always look for that presentation too. And it can be crippling for some patients, just crippling. And the longer they have inflammation and that's not addressed, the worse it gets. One of the saddest things that can happen is, and we've seen it a few times, where the anxiety can become so bad, it's almost paranoia, where they become afraid of the very medicine or whatever that could pull them out of it. And that's horrifying to see, where you know what's going on, you know what medicine will pull them out of it, and they just can't do it. So that was a huge, important discovery also.
Yeah. And the combination of all of those things, you're seeing recoveries,
Oh,
improvement,
yeah.
bit of both.
Our aim is always for recovery, always. And what happens with patients is that with consistency, and it takes a while because we're usually working towards some sort or against some sort of genetic tendency for some of this inflammation, you have to be extraordinarily consistent, keep some of this working properly, stay on top of it. And then the body has the opportunity to heal. When it heals and POTS goes away, okay, POTS will go away. That's just a presentation. Um, POTS goes away, then the patients need to know how did they get to that place and what is the least amount that they could do to maintain their health so it doesn't happen again. I know one fear I had once I had recovered was I felt so fragile in my recovery. I felt like if the cold virus came along, I would just, down and go. And it took a couple years really to feel stable with that recovery. And now I don't have fears of that. But I would be ready for some things if I did get COVID or what have you, or other viruses, or even high stress, surgeries, things like that can cause that. A car accident, trauma of most any sort can trigger such abnormal inflammation. You don't want that inflammation to run away. So it's important that patients leave that journey knowing what happened, what type of inflammation they deal with. My goal is to release the genetics of this, and I'm excited to do a lot of that, and started a group on Patreon called POTS Rebels, where we meet every week, we talk. I just put everything in there. Um, we've got to get out information for the masses, so that's a way to do that. But there's genetic components to some of our inability to handle some forms of inflammation. We need to know that as patients so we don't become sick again. I look at it like, and I think typically for other patients too, I'm always going to be an inflammatory patient. I know what I'm up against, but I'm not sick, nor do I plan to be sick. And I'm probably the most active person I know of basically any age. And I'd like to keep that too. So to walk away from a journey like this, being very proactive in my health, my vascular health, my brain health, etc., heart health, the whole bit, I think having gone through this journey, I will be healthier than my peers as I go into old age. And we can all be proactive. I think we should be. But had I not gotten POTS, I wouldn't have been nearly this proactive. Right. Um, so yeah, again, silver lining, but that's our goal with patients is full recovery with the knowledge of what happened and ultimately with them in charge of it so that they can stay on top of things if they ever get triggered again or what have you, and not slide backwards again. Yeah.
Yeah, I love that because I can relate to a lot of what you're saying. When I, did say, yes, I am now fully recovered, it
Yeah.
did feel fragile as well. I thought,
Mhm.
oh, this could so easily backslide.
Yes.
And I was really scared of that.
Yeah.
And, it took a bit of time to have more confidence in my recovery. It's like, I know I'm good. Okay, now I really know I'm good. And now, almost 2 years on, I'm
Yeah.
completely confident in that. But it did take a little bit of time. And,
Yeah.
I love what you're saying as well about maintaining health. When something like this happens, whether it's long COVID or ME/CFS or PoTS or dysautonomia, and obviously all of these have a lot of crossovers, we
Mhm.
get put into this position where we have to do everything we can to regain our health and
Yeah.
our wellness, to get our lives
Yeah.
back. And we have this greater appreciation, don't we, for what it means to be well and to be able
Yeah.
to function and enjoy life and just to be able to do boring, normal things. I remember being really excited about chores. It's like I can do chores
Yeah.
now, and then I very quickly decided chores were boring. But yeah, and I think it's so empowering. To have some of those tools, we learn them out of necessity, but they're tools for life. And
Yeah.
going forward, we've gained our health back, and that's wonderful. So it's about maintaining our health. What can I
Yeah.
do to make sure that I keep myself well? So for me, it's my morning breathwork practice. It's getting outside every day. It's continuing the cold water. It's some of those things that I did to get better. It's
Yeah.
keeping going with them. It's being aware of the impact of stress on the body. You can't avoid stress, but you can mitigate it.
Right.
So all of these things, what is it that's going to keep you well so you're
Mhm.
able to deal with what life throws at you? And I think,
Yeah.
we gain this appreciation. But yeah, health isn't free.
Yeah.
We do have to maintain it in whatever way that means for you. So yeah, I,
Right.
I love that the journey doesn't end with recovery. I think it keeps going. Um,
Yeah.
so yeah, that's super awesome. Um, I feel like we'd love to dive into research, but maybe we need to leave it there. And would you be willing to come back and talk research at some
I would
point?
love that. I would love that. One thing that happened to me, Jackie, and I think it's probably happened to you. My journey was so long,
Mm,
probably 12 years or so, that the empathy I feel toward patients never goes away.
mm.
So it's my life's mission to help other people out of this. I love talking to patients. I love answering questions. I do consultations around the world. um, and it isn't something I personally can walk away from. So until the treatment and evaluation paradigms change for these conditions and the labels, frankly, um, it's my life's work. So I'm always happy to talk, I will tell you. And there's just so many layers to these conditions. And patients struggle with that lack of validation, which just kills me. So yeah, absolutely. I would love that. I would love that. Research is always ongoing. Yeah.
Thank you. I'm so pleased you said that because, yes, I think it would be wonderful to dive into it and to do it justice.
Yeah.
So I will make sure that I drop all the things that you've mentioned, a link to your website, a link to your supplement that you've mentioned, anything else you want me to put in into the show notes so people can follow up any of that if they're interested.
Oh, well, thank
Um,
you. Yeah.
and yeah, I just want to say thank you so much for coming along and sharing your wisdom, sharing your story, and we'll do this again.
I've enjoyed it so much. So it was so nice to share time with you, Jackie. Thank you.
Thank you so much to all of my guests and to you for listening. I hope you've enjoyed it, or at least found it useful. The Long COVID podcast is entirely self-produced and self-funded. I'm doing all of this myself. If you're able to, please go to buymeacoffee.com/longcovidpod to help me cover the costs of hosting the podcast. Please look out for the next episode of the Long COVID podcast. It's available on all the usual podcast hosting things. And do get in touch. I'd love to hear from you.